We are good to go.
Good evening, everyone. I am Dr. Usha Sriram. I'm an endocrinologist based in Chennai, India. And I'm saying India because I know some people have joined from other parts of the globe as well. Today is a very special day. It's the eve of Valentine's Day. And you know that Valentine's Day is also extremely important to all of us because it's the day of sharing love and affection for all those we care about. And, keeping that in mind, and most importantly, if you saw the title of the program, it says Caring for the Sweetheart. And sweet stands for diabetes and heart stands for heart. So we are going to discuss today with two extraordinary experts who are joining us from Chicago, who are cardiologists, and not just cardiologists, but they have dedicated their work to heart health of women. And so we're going to talk about the effect of that diabetes and metabolic disorders, pre-diabetes and other disorders have on on the heart, and this is critically important. As we discussed today, we learned that for some reason, and we'll discuss that as well, women seem to be particularly vulnerable to many complications of diabetes, and right at the top is cardiovascular disease. So can we go to the next slide, please? Just wanted to say that today's program is largely about empowering the listeners about diabetes and heart health and how to stay healthy throughout one's life. But we know that, the current present time COVID, we think of it as a viral infection and think of all the problems that the lockdown has done to us. But it's really done something more to women. More women have been pushed into poverty. I think the UN says over 40 million women across the globe have gone below poverty line. Non-communicable diseases, they seem to again have been affected in terms of women not being able to access healthcare and possibly ignored symptoms, early symptoms, possibly not followed up. Those women who have had diabetes or heart disease or other non-communicable diseases. Mental health issues, and today we'll talk about the bidirectional relationship between mental health and heart disease, mental health and diabetes, and the three of them together, the kind of mischief they can create. And another important thing is some of the progress that has been made in this past decade or two, I think is going to be rolled back because of COVID, because resources, whether it's human resources or grants or research, are all being kind of channeled to COVID, which we know it's very important and needed to be done. But as they say in the US, we needed to chew gum and walk at the same time, and maybe that didn't happen, and everything went towards COVID. So this is what COVID is doing to women. I'm not even going into other things like, violence or caregiving stress or other things. Next slide, please. So just a couple of things. One is, myths versus reality. We have always thought of heart disease as a man's problem. So we'll discuss that today. Is it really a man's problem? And then when we think of women's health, we largely think of things like breast cancer or obesity or stress or things like that. So should we be talking about diabetes and heart and in relation to women? Next slide. Complications of diabetes are more in women. Is this a myth or is this a reality? Again, we'll talk about that. Next slide. So, what we want to achieve at the end of this is that awareness is really the best vaccine. Everybody understands vaccine now because vaccine is something that protects you from illness and complications and death. So awareness and health literacy is the best vaccine there is. And most importantly, unlike certain conditions about which we don't know much yet, like I'll just take an example like Parkinson's disease. I was at a lunch today and two of my friends were talking about Parkinson's disease and their family members, and just totally hit them from left field, and they don't know how it happened, and they don't know what they can do to prevent Parkinson's that could happen to them. Unlike those conditions, diabetes and heart disease, we know what can be done to prevent those conditions. So these are some of the things that we'll be talking about today. Next slide. So to do this, I couldn't think of a better person on this planet than Professor Annabelle Santos-Boardman, whom I've known for nearly 20 years. So Annabelle is the Macmillan-Ibel Endowed Chair for Excellence in Clinical Cardiology, Professor of Medicine, Rush College of Medicine, Medical Director, Rush Heart Center for Women, Vice Chief for Academic Affairs Division of Cardiology, Governor of the American College of Cardiology of Illinois this year, immediate past Chair of the American Heart Association Women in Cardiology, and 2020 recipient of the Women's Red Dress Award. This actually doesn't do justice to Annabelle because I've seen her in action. I've seen how she started the Heart Center for Women in 2003 and went from small group, kitchen table meetings to where we are now, and what the Go Red for Women has done in terms of actually decreasing the risk of heart disease in women, and the kind of impact it's had, and the kind of impact she's had on the mentoring she's done. So thank you, Annabelle, for being here today. Next slide, please. Professor Melissa Tracy, also at the Rush University Cardiology program, and I'm so grateful that you could join us today. And she's an assistant professor at the Department of Internal Medicine, Rush Medical College. She's the medical director of the Adult Echocardiography Lab. And I think this is particularly relevant to what we are going to talk about today because of the risk of heart failure in diabetes and heart failure in women, and the role of echocardiography in evaluating heart disease. Systems Medical Director, Cardiac Rehabilitation. Thank you, Professor Tracy, for joining us today, and we look forward to Annabelle and you enlightening all of us and the audience that's joined on all things women and heart disease. Next slide. This is me, you know me. I'm at the CAG VHS Endocrinology, Diabetes and Women's Health Department. I founded Diwas about 10 years ago, and a core committee member along with Chitra Selvan, who's here, and Shalini Jetty for the DD initiative, which is Diwas Integrated Diabetes Initiative. And I'm very thrilled to say that the president of the Indian Society for Bone and Mineral Research, which has been very close to my heart for many years. And most importantly, I really feel honored to be on the steering committee for women and diabetes for the International Diabetes Federation, and great work is already being done, and I think they will offer us a great platform to do more good work. And with that, I think we can move on to the actual discussion today with the panelists. Thank you so much. Next slide. So these are the moderators, and each one of them an outstanding woman endocrinologist, diabetologist from India, Nepal, Pakistan, and so willingly, one gynecologist, Dr. Umara, so willingly, jumped in and said yes for this evening's program. So thank each and every one of you. Thank you so much. Next slide.
Okay, so thank you, Dr. Usha, for that introduction, and extremely grateful to be part of this very important discussion. So if I can begin by directing this question to Professor Annabelle Wooten. So is it true that women are at high risk for heart disease? And if so, is there any particular age at which there's an inflection that we can clearly notice?
Thank you so much for that question, Dr. Chitra. Women are, of course, at risk for heart disease at all ages. There's a formula that we use. There are different kinds of heart disease, of course, and one of the most common is atherosclerosis, where high blood pressure, high cholesterol, diabetes, smoking, family history can cause plaque to form in the arteries of the heart, the brain, the kidneys, the legs, and it causes all kinds of bad things to happen to people. So that's atherosclerosis. And we have a formula that we use in the United States called the atherosclerotic cardiovascular risk. And it takes into account all of those risk factors, plus your blood pressure at the time that you're calculating the risk, the cholesterol at the time that they're calculating the risk, the race. So whether you're South Asian, and South Asians are definitely at higher risk for atherosclerosis, as you all know, not only diabetes, but heart disease. And that's why South Asians, and that's why we're doing this today, because South Asians are at higher risk than almost all other races and ethnicity for early heart disease, early heart attacks, early sudden cardiac death. So that's the most common heart disease. But women are particularly at high risk for valvular heart disease, heart failure, and the kind of heart failure that women get is that they have a strong heart, what we call heart failure with preserved ejection fraction. And unfortunately, we don't have as many treatments or as proven treatments for that kind of heart failure. We see this in diabetics. We see this in older people with hypertension. So unfortunately, the best way not to get heart failure with preserved ejection fraction is to treat that blood pressure, to prevent diabetes. And then the valvular heart disease, as you know, rheumatic heart disease affects more women than men, and valvular heart disease in general affects more women than men. So yes, women are at high risk for heart disease, but different kinds. And arrhythmias, of course. Men get more atrial fibrillation, but women with valve disease and hypertension certainly are at risk for atrial fibrillation and lots of palpitations. There are a lot of women who are anxious, who are under a lot of stress, and they feel their hearts pounding. And a lot of these women are really dismissed by doctors. Yeah. And they keep telling them, oh, don't worry about it. It's just your stress. Well, that stress can eventually lead to a lot of bad things like diabetes and hypertension. So we need to pay attention to these symptoms of palpitations in women. I know that's a long answer.
No, that was the best kind of answer. So if I can just ask, does menopause accelerate atherosclerotic cardiovascular disease in women?
Is that for me?
Yeah.
So menopause is very complicated. We are not absolutely sure that it's menopause that causes that acceleration. We know that women are, it used to be 10 years older when they get heart disease than men, but now it's 7 years that gap has decreased as women have had more hypertension, more diabetes, more risk factors. Women are getting heart disease at a younger age, that atherosclerosis that we're talking about. Men have taken better care of themselves and women have not. They continue to think that heart disease is a man's disease, that they're not going to be affected by heart disease. So they are not taking good care of themselves. And so as we get older, there's more probability that we're going to get heart disease. And so menopause is part of the aging process. But we think that estrogen does have some positive effects. When we start estrogen at a younger age, less than 10 years after menopause, there seems to be some positive benefits, but it's not recommended to decrease heart disease. It's recommended to give women hormone replacement therapy if they're symptomatic, if they're severely symptomatic from menopause. But please make sure that you're checking the blood pressure, checking the triglycerides, because that can cause those high elevations of those things when you give hormone replacement therapy.
Yes.
Thank you.
Thank you so much. Thank you so much, Professor Annabelle. Could we have the slide up, please? Over to Dr. Vijayalakshmi.
Yeah. Good evening, everyone. My question would be addressed to Dr. Usha. Since, ma'am, you've been a very passionate advocate for women's health and diabetes, and also given the wonderful work you've been doing through Diwas, spearheading programs like Sahodris, where you've been taking care of both socially and economically deprived women. Does diabetes pose a bigger challenge for women? And also because they go through a big seesaw of not only emotional, but also hormonal challenges right from puberty to menopause. So we would like to know from you about how challenging diabetes can be for women, ma'am.
Thank you so much, Vijay. Dr. Vijayalakshmi is an associate of mine and takes care of all our patients with gestational diabetes and type 1 diabetes. And I thank you, Vijay, for doing that. So the question is, what makes diabetes a bigger challenge for women? So first thing is, it's a straightforward, yes, it's a bigger challenge for women. And the thing is this, even though the number of women and number of men in the world with diabetes are about equal. Okay? So for example, in India, we have nearly 80 million people with diabetes, close to 40 million are women. Having said that, when you look at the complications that happen, much more women have complications. For example, what Dr. Annabelle Bogman was talking about, heart disease, heart attacks, more women with diabetes have that problem. Stroke. Women with diabetes are also at greater risk for progressive kidney disease. So end-stage kidney disease. They're also at greater risk for fractures, osteoporosis and fractures. And this was also confirmed in a large Indian study called INDIAB study that confirmed that somehow diabetes increases risk of fractures osteoporosis is a bigger problem in women to start with. And when you take diabetes, there's much more osteoporosis and fractures in women. And then two more things which we somehow don't associate with diabetes. So one is depression. Depression again is more common in women to start with, but when you take women with diabetes, more depression in women than men with diabetes. So then the last one, which has kind of come into our radar recently, and I think we are going to talk about that later today, is cancer. So there's a 27% increased risk of cancer in women with diabetes compared to women without. Men have about I think a 19% increase. So women have a 7% increased risk of cancer compared to women without diabetes. So as you can see, all these things are a bigger challenge for women. I mean, that apart, the female gender, mean us, in terms of the experience of diabetes that we have, is a bigger challenge for women, because it may be something to do with, can we afford the treatment? Can they balance their caregiving responsibilities with self-care? So that experience. So many such things, and who is going to take care of them? So many of those things add on to these other complications that I already talked about. And then there are some fundamental, see, there's the male sex and the female sex. So there are hormonal differences and other biological differences. And just on that basis, there are huge differences between men and women. And last two things I want to say is the amount of diabetes that women have is on the rise. So much so, globally and in India, the lifetime risk of diabetes is higher in women. So that is a very big problem. And other things that we'll talk about later keep adding to this risk. So we don't kind of see an end in sight unless we really take the bull by the horn and do something like the Go Red. So one of the reasons why I keep bringing Annabelle back is I'm hoping that we'll have a program like that for diabetes and everything will get better. Thank you.
Can we please have the slide deck back up?
Just one more thing, ma'am. Would you like to add a few words about how gestational diabetes can be a huge window of opportunity for us to change the course of the disease in these women?
Oh, completely. Thank you, Vijay. I was kind of reserving it for a later thing, but I'll talk about it. Gestational diabetes is diabetes that happens during pregnancy. And so there's this dismissive attitude towards that. Oh, it's a temporary thing that happens during pregnancy. It goes away after I have the baby, and then everything is fine. Unfortunately, that's not the case. Women who have gestational diabetes are at much greater risk for future diabetes. And when we say future, we're not talking 20, 30 years later, but within the next 5 to 10 years, anywhere from 50 to 70% develop type 2 diabetes. And so you can see they're all very, very young people. And so if we can first prevent gestational diabetes, if not, take better care of it, and then post-delivery, follow these women, because it's a real low-hanging fruit. If we can address these women and make sure that with their next pregnancy they don't get it, or that they don't go on to developing type 2 diabetes and cardiovascular disease, we would have done great service to a large chunk of women. In India alone, every year, 3 to 5 million women with gestational diabetes.
Thank you, ma'am.
So thanks, Dr. Usha ma'am and Dr. Annabelle, for those wonderful insights. So I'll want to request Dr. Melissa to address this question. We've heard about some traditional risk factors for heart disease that we do understand, but are there any risk factors that are unique for women and that we don't really address or talk about much?
This foundational. I just want to press we're here because definitely cardiovascular disease is the leading cause of death worldwide for women. And if we don't accept that and acknowledge that, that will continue. And a lot of the factors that are involved in cardiovascular death are modifiable. And so we really need to address this with our women patients, our female patients. And I did hear one of the speakers earlier say about the caretakers. In a study here in the United States, 58% of women are still the primary caretaker of their family. However, they put their needs in the queue. They'll make sure that their spouse or their parents or a friend or a sister or a brother gets to address their cardiovascular disease and their issue go in the queue. So we have to also empower women to know that they must take care first. If they don't take care of themselves first, they cannot be as well of a provider for all those other people they love. Based on risk factors, the traditional risk factors are still very, very important for us not to underscore. So the traditional risk factors and appropriate treatment for those risk factors are important. Hypertension, diabetes, high cholesterol, obesity, inactivity. In this country, we're having a huge problem with e-cigarettes and vapes and juuls. We have to make sure that our female patients understand that those alternative methods of taking in tobacco are also causing harm, but also their exposure to second and third hand smoke. So the traditional risk factors are very important. Those that we tend to not talk about or shun away is there are hormonal factors that women need to address. And using estrogen or progesterone for the need for perimenopause or menopause symptoms can be considered, but are not the go-to that we should be thinking about. We have to think about what happens in pregnancy. Many studies have shown that what occurs in pregnancy not only shortly thereafter can affect women, but in the long term. So women who have had preterm labor, women who have had gestational diabetes, women who have had preeclampsia or eclampsia or hypertension that occurs during or post-pregnancy. Very, very important because those have both short and long-term adverse effects on our female patients. Peri and postpartum cardiomyopathy. How many women, unfortunately, this goes underdiagnosed or do not heed the advice that they should not consider subsequent pregnancies, because we know that even if a woman recovers from a peri or postpartum cardiomyopathy, her risk of developing that cardiomyopathy in a subsequent pregnancy is huge. And the chances of that cardiomyopathy, weak heart muscle, being even more effective adversely on her health and or resulting in premature death. If any of those factors result in premature death, she has now left her children and her family without their monarch. And we all know how important the monarch is in our family. In addition, other risk factors include connective tissue disorders. There's definitely a connection with rheumatoid arthritis and lupus to the development of cardiovascular disease. We have to think about cancer and cancer treatments. There's a lot of adverse effects that happen not only with the endogenous, if we're taking in oral medication or through our intravenous chemotherapy, but radiation. So those are all factors. And then finally, definitely depression, anxiety, panic. How many times women get diagnosed with anxiety, depression, or panic, but then their cardiovascular risk factors are not addressed? I always tell my patients, sure, you may be anxious, you may be depressed, but those are going to be in the lower end of what I'm going to work up and rule out. I need to rule out that you have cardiovascular disease, and in conjunction, deal with if these are contributing to your anxiety, depression, or your anxiety or depression are contributing to the acceleration of your risk factors or cardiovascular disease. And then finally, definitely social economic. We know that social economic risk factors can affect both men and women, but they tend to affect women more so. So all of these factors we need to address. We need to stop with looking at a woman and calling it atypical symptoms or atypical chest pain. And that was recently addressed in the updated American Heart Association for chest pain. We no longer should use atypical. It should be, is this cardiac or not cardiac? Because that patient of atypical then drops women into level of abyss, and their symptoms or their concerns are then just all endorsed to their anxiety and possibly all of their risk factors are.
Thank you, Dr. Melissa. Can we have the slide deck up? And maybe Dr. Shruti, you wanted to ask something.
Yeah. My question is to Dr. Tracy. What are the symptoms of heart disease that women should be aware of?
So that I gave a great segue, excuse me, from the updated guidelines. So women can and do have still the traditional symptoms. Sorry, my Zoom there we go. So again, women can and do still have the traditional symptoms. They do still have the substernal chest pressure or chest pain, possibly radiating up to the jaw, to the arm, occurring with exertion or stress. However, women may have additional atypical risk factors or symptoms, and those may include, they may not have those traditional symptoms. They may have more shortness of breath. So instead of the substernal chest pressure or pain, they may have more shortness of breath, which occurs with exertion or stress. They may just have the jaw tightness, or they may have just arm discomfort. They may notice that they have decreased exercise tolerance. I had one patient that I saw many years ago. She was in her 40s, had 2 children, still menstruating. And she came to me because she noticed that when she was taking her children around the lake that was near her house, she could not complete the lake. She just was excessively fatigued. She did not have chest pressure or chest pain. She didn't have jaw pain, and not really that much shortness of breath. It was actually more just inability to complete her tasks. Women may have more anxiety and depression because they may not be able to completely understand what is happening to them. They know something is wrong. And so now they start feeling more anxious, more panicked. And there again, that's where I tell my patients, sure, this may be anxiety or depression, but you're here to see a cardiologist. I want to make sure that I rule out any symptoms that may be related to cardiovascular disease or cardiovascular disease risk factors. Women may have more inability to sleep. They may have more trouble falling asleep or staying asleep. I think the key thing that I want to say about these symptoms that are not typical symptoms is that we also don't want to scare our female patients. If you look, you can find a multitude of risk factors. We can all suffer from insomnia. We can all suffer from having decreased exercise tolerance, but you want to listen to the pattern. So regardless of the symptoms, I think we're all really good detectives, and we want to listen to the pattern of these symptoms. So regardless if the patient has typical or atypical symptoms, ask them, when are these occurring? Are they occurring when you're exerting yourself? Are they occurring when you find yourself being more stressed? Because regardless of the symptom, there will still be that pattern, that a symptom that is specific to that patient, or symptoms which are specific to that patient, may occur, or more likely will occur, with exertion, with stress. And they'll notice that if these symptoms go undertreated, that those are going to then start occurring with less exertion or with less stress, and then possibly occurring at rest. And so then they are having progression of their symptoms, whether typical or atypical, and they're going undertreated. And after going undertreated or underdiagnosed, any of their risk factors are also going undertreated or underdiagnosed. And then we're going to have an acceleration of risk factors. And then we're going to have our female patient coming in with a massive heart attack or full-blown heart failure or arrhythmias or progressive peripheral arterial disease. So we need to, women sitting back, listening to their symptoms, and being an advocate for their health. Women need to feel empowered to bring those symptoms, whether they feel it is from their heart or not, bring those symptoms first to their primary care physician. If their primary care physician or their endocrinologist feels that this may be associated with coronary and cardiovascular disease, refer them to a cardiologist, and don't underrate or under influence their symptoms and just shut it off. Make sure that these women are heard and make sure that these women are empowered.
Thank you so much, Dr. Tracy. Thanks a lot.
Hello, Dr. Melissa. It's really been interesting to listen to your talk. And really, like you said, we are all our little detectives and we don't want to undermine what our patient is feeling. So I think my next question to pose to you is like, especially given that we are in a low economy and we pay out of our pockets in our settings. I'm from Nepal. So when is it that we want to think, what are the red flags, and really what is the test that we recommend to assess the heart health in women? And is it going to be different for menopausal and premenopausal women? Like, would you do different sets of tests? Like, how would that work?
Thank you so much. So when a female patient comes in with symptoms which we may consider are suggestive of cardiovascular disease, that patient right off the bat gets just a standard 12-lead EKG, gets a full history and physical, and then I take into consideration what illnesses, what specific cardiovascular diseases am I trying to evaluate for. So if this patient has long-term hypertension or their symptoms appear to be associated with pregnancy or postpartum, performing an echocardiogram is going to be key, looking to see if they have concentric left ventricular hypertrophy from long-term hypertension, looking to see if they have a weak heart muscle, so they have a cardiomyopathy, and looking also at their diastolic function. We put a lot of emphasis into a thorough diastolic evaluation because, as Dr. Vogtman had alluded to earlier, heart failure with preserved EF, HFpEF, is becoming more and more prevalent, especially in women, especially in older women, and especially in African American women. And so we want to make sure that we're carefully looking at their diastolic heart failure or diastolic parameters, as well as their systolic parameters, evaluating all their valves, making sure, do they have mitral valve prolapse with significant mitral valve regurgitation? Have they developed any mitral stenosis or aortic stenosis after they've had chest radiation for their cancer? Do they have any attack on any of their valves from their systemic connective tissue or inflammatory diseases, as we know that those can also affect the valves? So standard 12-lead EKG still has very good prognostic availability and a detailed echocardiogram. It is important that our female patients also understand that there's a use of contrast enhancing agent that can be used with the procedure of an echocardiogram. And it's unfortunate that it has the term contrast in it because it doesn't affect the kidneys as a lot of patients are so concerned about. But women may need more utilization of contrast enhancing agents with their echocardiogram because of possible breast attenuation. So we want to make sure that our patients understand that they may require an IV during their echo and that they may need to have contrast enhancing agent. If I feel that a patient needs a stress test, unfortunately in this country, insurers will dictate whether or not I can go to a stress test with imaging or I have to start with the standard EKG stress test. I particularly do not like to do standard stress testing with just EKG if that patient has, in my opinion, a intermediate or higher risk pretest probability for having cardiovascular disease. The sensitivity and specificity for a routine 12-lead EKG exercise stress test without imaging lower sensitivity and lower specificity in women. And then what results is I then have to bring them back and then couple it with an imaging modality. So unfortunately, in this country, we may be dictated by insurance companies. I like to use exercise if I'm going to use a stress test, which has imaging, if that is nuclear or if that is echo, because you get so much valuable information from the exercise component. You look to see what is their heart rate response to exercise as well as to recovery. In a well-conditioned heart, a patient is going to have an upslope of their heart rate and their blood pressure in a longer, more protracted fashion. That is a really good prognostic sign. If it takes a longer time for your patient, regardless of male or female, to reach target heart rate, that is a well-conditioned heart. You want to look at the blood pressure response. With exercise, the systolic blood pressure will go up to a point. The diastolic blood pressure should stay the same or fall with exercise. So then we look to see if they have a hypertensive response to exercise, or do they have an exaggerated heart rate response to exercise? Then you want to look at how the parameters develop into recovery. A well-conditioned heart, their heart rate is going to recover quickly. Their blood pressure is going to lower at a quicker fashion. So you want to look to see how their heart rate and blood pressure then respond to recovery. I am an echocardiographer, so I really do like stress echo. Again, we use contrast enhancing agent with almost all of our stress echoes because you cannot predict how much the breathing is going to affect getting your images. So for us, we use contrast enhancing agent on almost all of our stress echoes. And that really gives a nice definition between the cavity of the left ventricle and the myocardium. So you can see nicely how well all of your 16 or 17 different segments are responding. You also can see, is there appropriate contractility? Does the left ventricle dilate with exercise? We don't want the left ventricle to dilate with exercise. And we definitely want to see a more robust thickening and contractility to the LV. If the patient doesn't want a stress echo, or the cardiologist does not feel a stress echo will be ideal, definitely a nuclear stress test would be the next study that I would go to. And the thing that I like about nuclear stress tests is if a patient cannot achieve the designated heart rate response, so at least 85% of the maximum predicted heart rate, that stress nuclear can be easily then converted to a pharmacological stress test. So that's a nice way, is that if you're on the fence, if your patient will be able to achieve the maximum predicted heart rate, whether it's that they're deconditioned. Sorry, I'm going to take a sip of water.
Sure.
If your patient is deconditioned or has some arthritic factors relative to their connective tissue disorder or their rheumatoid arthritis, or they have osteoarthritis, then it's a great test to go to. You also need to look to see what is the strength at your particular institution. Is the strength at your particular institution stress echo? Is your strength nuclear stress test, or do you have a choice? We are very fortunate at Rush to have a very efficient echo lab with excellent sonographers to capture those images, and we have an excellent nuclear stress test. But again, the nuclear is great, because if I am concerned that a patient is not going to be able to get to target, then I can easily convert that stress test to a pharmacological stress test. What I like about both stress echo and nuclear is that we can look beyond just systolic or obstructive coronary disease. With echo, we do a thorough diastology evaluation. So if a woman has an abnormal diastolic functional response to exercise and has normal systolic response with no segmental wall motion abnormalities, that woman may have microvascular disease that is being demonstrated by their abnormal diastolic functional response. In addition, with nuclear stress, we can look at the myocardial perfusion and look to see how well is their myocardium being preserved. And we can look at what we call the response to exercise with the myocardial reserve capacity. And so both of the nuclear and echo. I'm sorry?
No, sorry. That's good.
Was there a question? I'm sorry.
No, sorry. I was going to, please continue. No, I was going to. Sorry. Okay. Can you hear me now? Yes. So unfortunately, in our institution, I don't know about the others, like we don't have either of them. So we are stuck between, yeah. So that's why I was like, I love what you're talking about, but we don't have nuclear, we don't have pharmacology, we just have normal echo, or we have an option, like you said, the TMT, the treadmill test, which we do the exercise. And then we usually send people for an angiogram, which can now is an option that which is a CT angio. So, I mean, I'm just like lost because we just have a normal echogram that.
Bring me sonographers, and we will get you to be able to offer stress echo. Stress echo is an amazing study because you don't need the radiation from a nuclear stress test. If you have a good sonographer and a good nurse and a patient who's willing to get on the treadmill, you have a diagnostic tool that is so valuable. So stress echo, I am, as I said, I'm a bit biased because I'm an echocardiographer, but you can get such valuable information. To the exercise component, like I said, gives you such valuable information. So on that treadmill stress test, which you guys do have, which is great, do look beyond the EKG, because how many times the EKG is a mess during exercise because of the breathing and the movement of the patient. So definitely look at how well is that heart rate responding? Is it exaggerated response? Does it go up right away? Does the blood pressure become hypertensive? Two really important prognostic signs to look at. Then how do those parameters recover? Again, a well-conditioned heart, the heart rate is going to come down well and pretty quickly. The blood pressure will come down pretty well, pretty quickly. Look at for arrhythmias, as Dr. Voldman alluded to earlier. Are there more ventricular ectopies during exercise? Are there any arrhythmias occurring during exercise? So really important to also look at arrhythmias. If you unfortunately don't have one of these stress tests, yes, you can absolutely do an angiogram. However, it's an invasive test. You're going from a treadmill study, which again has a lower sensitivity and a lower specificity in our female patients, to an invasive study, which again may not give us the information we need, because one, women have smaller coronaries than men, and women can have more microvascular disease. And if your interventionist does not know how to look for microvascular disease by a cardiac catheterization, they're going to only be looking for large vessel coronary disease. And which affects women more than men, microvascular disease is going to be missed. And we know that women, if they do not have large vessel disease and have small vessel disease or microvascular disease or endothelial dysfunction, have a worse prognosis. They have a worse prognosis than patients who have no coronary artery disease, and they have a worse prognosis than patients with large vessel coronary artery disease. And that's mostly for the fact that they are undertreated. So if you're doing
I interrupt?
Or large. Yes, I'm sorry. Go ahead.
Sorry, can we come back to the discussion because we're running a little behind? So do you mind? We can come back to this. Dina, do you mind?
No, not at all. I think we got our answer almost.
Very important question. We'll come back to it. So can we move to the next one, if you don't mind?
I'd say one thing, angiogram, women also have more adverse outcomes during their angiogram, and those can result in serious cardiovascular events.
Thank you so much.
Thank you so much. So many valuable points from Dr. Tracy. Thank you, Dr. Tracy. My question is for Dr. Usha. DTM is probably a warning bell when the woman doesn't take adequate care. That results in diabetes. But besides gestational diabetes mellitus, are there any reasons which make women more susceptible to diabetes? Why do women have more diabetes? Dr. Usha, please.
So I like to put the reasons why women have more diabetes and the factors they have more diabetes into two buckets. One is lifestyle, and the other one I call life cycle. So the lifestyle are things like urbanization, globalization, which is common for men and women, but women seem to be particularly vulnerable to urbanization and globalization because our roles have changed. We are now balancing traditional roles and the new roles that the roles that we have evolved. So that's one of the things, this whole urbanization, globalization. And second thing is, as a consequence of that, there's more obesity and overweight in women all across the globe, all age groups. So big, huge risk factor for diabetes is overweight and obesity. And so that's the second one. The third one is what is causing the obesity is physical inactivity. Again, studies from India, globally, everywhere they've shown that, women are more physically inactive compared to men. We don't want to admit it. We are very busy people, but we are physically more inactive than men. So more diabetes because of that. And then, of course, all this processed food and eating habits have changed. So all these are the more sitting. So the jobs that women have taken, especially in low and middle income countries, because if you look at it right now, the International Diabetes Federation says we have 537 million people with diabetes and going somewhere towards 645 by 2030. Chances are we'll go there in the next 2 to 3 years and not till at 2030. And the big jump in women is because, again, the change in lifestyle, it's a lot of sedentary jobs for women, IT industry. And so the sitting is another risk factor. So this is all the lifestyle. Now you take the life cycle, pregnancy itself is a risk factor. The more pregnancies you have. Second, gestational diabetes. Third, this polycystic ovary syndrome, a unique problem for women. The most common endocrine disorder in women of reproductive age, something like 7 times increased risk of diabetes, in 4 to 7 times increased risk of diabetes in girls and women with polycystic ovary syndrome. And quickly to revisit menopause. Menopause does funny things with, and diabetes. At menopause, women have some weight gain. There's more importantly, a change in body composition. There's more upper body obesity, a redistribution of the fat, and the change in body composition, lipid profile, and so these things, and possibly some more physical inactivity due to the menopausal symptoms, there's a higher risk. So all this is adding up. Then there's another component, which is more caregiving is done by women throughout their life, and caregiving itself is a risk factor because there's not time for self-care. The stress of giving care, caregiver fatigue is very, a lot of depression, and that can increase the risk. And also there's not enough money to take care of themselves or time. So caregiving is a risk factor for things like diabetes. And then poverty. More women in the world are poor than men. 70% of the poor in the world are women. And I just mentioned COVID has pushed more people below the poverty line. And what has poverty got to do with diabetes? Everything from the built environment they are in, to the kind of foods they can eat, to the physical activity they can do, lack of access to healthcare. So many things. So poverty increases the risk. In India, in 8 of the major metros, the poor have more diabetes than the rich. So it's something that we really need to pay serious attention to. So these are all the reasons, and on top of that, we have gestational diabetes and other things. So you can see why women have more diabetes. So the short answer is eat better, move more, less babies, prevent GDM, less stress, and get women out of poverty. So these are the risk factors.
Thank you so much.
Yeah.
The next slide, please.
So thank you, Usha, for highlighting very important aspects. So going back to the prevention strategies in women to improve their heart health, my question to Dr. Annabelle is that, is there a special diet that is good for women to have better heart health?
Well, I don't know if it's particularly for women, but in terms of diets, there are several different kinds of diet that have been studied to see what can decrease heart disease. The most famous one, of course, is the Mediterranean diet. And as Dr. Shriram knows, we did a lot of conferences and community activities to teach different ethnic groups about being heart healthy. As you can imagine, I'm Filipino, several of you are Indian, and you're not going to eat the Mediterranean diet as, to change your life completely. So we have to adjust what we recommend to different ethnicities. So when we do our programs for the community, we do teach them how to decrease their saturated fat intake, how to eat more fruits and vegetables. There are different kinds of diets out there called the Mediterranean diet, the DASH diet, which is a dietary approach to stop hypertension, DASH, which is well known to decrease high blood pressure. And actually, the nutritionists at Rush combined the Mediterranean diet and the DASH diet to find out if a diet that's the combination of both can decrease cognitive impairment. It's called the MIND diet. So it's a combination of the Mediterranean and the DASH diet. It's called the MIND diet, M-I-N-D. And we're enrolling people right now and following them to see if they follow this 2 diets, if we can decrease cognitive impairment and Alzheimer's and dementia in these people. So very interesting. And then of course I have to talk about the vegan and the vegetarian diet. As most of you know, the Indian people are mostly vegetarian, but and Dr. Shriram has educated me about the unhealthiness of some of the vegetarian diets that Indian people have. You use a lot of ghee, which is a lot of saturated fat. So we're trying to get them to use less saturated fats in their diet. A healthy diet consists of all different kinds of foods, very colorful diet, so that you get all the vitamins and the nutrients that a body needs, because food is medicine. We all need to eat to be healthy, but we want to make sure that we're putting all the right things in our bodies. The vegetarian diet, or the vegan diet especially, has been found to decrease saturated fats, and it's associated with decreased risk of heart failure, hypertension, and also cancers. So it's an excellent diet. If you're willing to go vegan, that's the best way to lower some of the risks that people have. I hope that answers your question.
Thank you very much. So can we have the next slide?
Annabelle, Aisha is joining us from Pakistan, a dear friend of mine and a friend of Diwas. Thank you, Aisha, for doing this.
Thank you.
Thank you, Usha, for inviting me.
Yeah.
I'm going to step in for Dr. Jayashree and ask this question to Dr. Melissa. If you can quickly tell us some of the best exercises or physical activity for better heart health, and for how long should we be doing these exercises on a daily or a weekly basis? Dr. Melissa, please.
So I put my AirPods in. Can you hear me better? Because Dr. Vogtman had sent me. Perfect. Okay. And I apologize. I did not originally have those in. So this is a great question for me, for both personal as well as professional reasons. I've been an athlete my entire life. I was a swimmer and in high school and college. And when I got to medical school, there was no ability to swim because your hours were a bit erratic. So I started running, and I've been running ever since. And so I have a passion for exercise in general. And that passion for exercise personally has been able to take me to where I can help patients in my professional career. And so I am the systems director for cardiac rehab. My screen is frozen. Can everybody still hear me?
Yes, we can hear you and see you.
Okay. All right. I just saw that my screen went frozen, so I wanted to make sure I was still on. So being the systems director for cardiac rehab, I overlook cardiac rehab at all of our facilities. I've created 3 cardiac rehab programs, 2 at my place of employment at the University of Miami, and then at Rush. So this is an area that I am so passionate about. There's no needles, there's no probing. We get to take patients from the inability to exercise or bring them back to where they want to exercise after a cardiovascular event. So for women, it is really important that women understand that not only is aerobic exercise important, so getting them out running or jogging or on a bicycle, that is key for cardiovascular health. However, women also need to know that they need muscle. Muscle makes our body a more efficient machine. And women are so concerned about doing weights that they're going to end up looking like Arnold Schwarzenegger. We don't have enough testosterone in our bodies naturally to look like Arnold Schwarzenegger. But muscle definition and muscle strength, one, I tell my female patients, is beautiful. Sculpt your body. So I want women to also lift weights. In addition to becoming a more efficient machine. And what I mean by that is anything we take in, we're going to burn off better if we're a more efficient machine. But muscle is also going to protect the bones. And so we want women to have more more muscle strength so that as they mature in age, their bones will be protected. Women, because of that primary caretaker position, tend to once again not give themselves enough me time to exercise. And I tell my female patients, only you can give yourself that gift. By you taking the time out of your day, carving that out, that is a gift that you're giving to yourself. Nobody else can do that for you. So I want women to become advocates for their own health. Carve out time at least 3 times per week, work it up to 5 times per week, where you get in some moderate exercise. And what we have found is it doesn't have to also be 30 minutes in a row. If we have our patients using stairs rather than elevators or escalators, walking to the store, at the store instead of pushing a cart, getting a basket, parking if they are driving, parking farther out in the parking lot and walking. Those also, if you do those every day, accumulate that movement And I like to use the word movement because some people are very intimidated by using exercise. Embrace movement. So get movement into your life. We all move every day. So again, stairs, lifting a cart rather than pushing a cart, and walking. And then decide, can you get that momentum up? So once a patient gets to a aerobic capacity where they're not challenged, and what I mean by challenged is they do want to break a little sweat. I think sweat is awesome. So break a sweat and have a little bit more difficulty in your breathing. So you still want to have a conversation, but it should be a little bit more labored. Now step it up. So if it's walking, go to jogging or get on a bicycle. Get on a bicycle with your kids. Oh my gosh, your kids would love to do this with you. My children all see me exercise, and they all know that I do this not only for my cardiovascular health, but my mental health. It is a way that I can regroup mentally. And again, I'm doing it for myself. I'm an advocate for me. Women also may then say, okay, I just don't have the time. So a lot of women like what we call high intensity training. And high intensity training is that they do exercise for a shorter amount of time, but they really elevate the intensity. That is not typically where I like patients to start if they have not had a background in exercise. That is something that we can work up to. So I want patients moving. Movement is important. Strength is important. And it's important for your cardiovascular health. It's also important for your mental health. And do it as many times per week as possible. And again, if you can't get in 30, 40, 45 minutes at one time, it can be an accumulative effect that you can have over your day. So keep moving.
Thank you, Dr. Melissa. Can we have the slides back up? And Arundhati, you wanted to add something. Thanks.
Yes, my question would be to Dr. Usha, ma'am. We hear a lot about these new diets, and intermittent fasting is something that is the very in thing kinds. So is it actually good for diabetes and or heart health?
Thanks, Arundhati. I'll answer it very briefly and I'll ask Annabelle to also chime in. So this whole intermittent fasting, or what we now like to call it as timed eating, has completely changed all the things we knew about, diet and food on its head. For example, we always thought breakfast is the most important meal of the day. And in intermittent fasting, where's the breakfast, right? So there's no breakfast. And then we always thought that, protein, if it happens to be good, like fish or chicken or things like that, is very, very good for you. And now we are talking a lot about plant-based food and we're talking a lot about vegetarian food. So a lot of things have changed. And we always thought that not eating is not, and especially for diabetes, we told patients to eat 6 times a day, 3 meals and 3 snacks, or graze like an animal throughout the day. Completely, this has changed because the reason, the rationale is when you just eat 2 meals and there's a huge gap between the two, the amount of, because only when you eat, the sugar goes up. And only when the sugar goes up, insulin goes up. So the whole idea is when you eat only 2 times, there's only 2 spikes of insulin. So very important that there is this postprandial insulin spike is less. And then, so many things like insulin sensitivity is supposed to be better, oxidative stress is less. And most importantly, because there's no insulin, the fat has to burn. And when fat burns, there are ketone bodies. And that is an appetite suppressant like nothing else. So people actually feel, you would think that if you don't eat for hours and hours, you'll be ravenously hungry. But actually, it totally kills your appetite. So I'm just saying that the whole intermittent fasting has had a, what can I say, a rebirth of sorts, but more better rooted in science, the evidence. And but it's not for everyone. Obviously not for people who have brittle diabetes or hypoglycemia prone or eating disorders, or they have health issues where the food has to be timed with their medications and things like that. So it's not for everyone. Annabelle, you want to jump in?
Yeah, thank you so much. I think that we don't know the answer to that question yet. There have been some studies that are being done as we currently speak, that the American Heart Association is actually funding to see if intermittent fasting is good for weight loss and for obesity and diabetes and heart disease. But I don't think we know the answer yet. We know that some people are successful in losing weight with the intermittent fasting, but whether this is really healthy or good for the heart or to prevent diabetes is not really well known at this point. So stay tuned, and in a few years, I think we'll have some answers.
Yes. Next question, please.
Good evening, ma'am. It has been a wonderful session going on. My question is to Usha, ma'am. Ma'am, is there any contribution of yoga and meditation and its effect on the control with diabetes?
Short answer is big yes. Yoga is like a 5,000-year-old, practice, and it's a kind of balancing physical, mental, emotional, all of that. And it's not just a discipline. We used to think that it just gave you discipline, but now we know it not only is discipline, but there is flexibility, mindfulness. There's actual changes in metabolic rate. There's actual changes in autonomic function. So many actual changes are taking place. And also there's some data to show that it may actually be working on not just through lowering stress and therefore stress hormones and effect on the metabolic health, but direct effect even on the potentially on the pancreas. So different exercises from Kapalbhati to Surya Namaskar to so many different asanas and mudras and so many things that are done as part of yoga, I think has great benefit. And I just think it's, and of course, the whole breathing exercise is also, pranayama is included as part of yoga. And all of those have shown great benefit for, diabetes control, weight control, and actually lowering blood pressure and CV risk factors like that. So when someone asks me, is yoga and meditation good for diabetes, I just tell them absolutely, and I encourage all of them to take it up, but it can't be the only thing. So it has to be a adjunct to whatever else we are doing medically for the patient, because I don't want people to, I glorified it so much. I don't want them to stop all their medicines and go do just that. So it's a great complementary therapeutic tool with all the other things that we do. But I think it's a great addition.
Thank you, ma'am. Thank you so much.
I hope I can add just a few words about this, because I have used transcendental meditation as a very powerful tool for several of my patients who have had severe anxiety and a lot of stress, and they just can't tolerate a lot of the medications to lower their blood pressure. And transcendental meditation has really been so helpful as a practice, in addition to all the medical treatment that we give them. Another thing that we know about yoga is that it has been shown to decrease the risk of atrial fibrillation. So in patients who have atrial fibrillation, which can potentially cause strokes in people, that has been very helpful in certain patients.
And Dhruvi, if I may add, many patients have limitations to regular physical activity. They may have, with diabetes, limited joint mobility or knee issues or weight issues, and yoga and meditation are great alternatives for them.
Thank you so much. Thank you, Dr. Annabelle. Thank you, Usha ma'am.
So if I can ask Dr. Melissa to tell us the link between mental health and the risk for heart disease, specifically in women. Dr. Melissa, please.
Thank you. So we alluded to this earlier as well, but I think the key with mental health and women are two. One, diagnosing it, and two, appropriately treating it. There are a multitude of studies that demonstrate that when a patient is diagnosed with a cardiovascular event, that cardiovascular event may trigger anxiety or depression, or may bring to the surface the additional anxiety or depression that patient had. And if their anxiety, depression, or panic are not equally treated as their cardiovascular disease risk factors are treated, those patients have a statistically significant worse outcome for both mortality and morbidity. So it is really important that we make sure that we are identifying that there is a component of anxiety or depression and treating it. And it doesn't have to always be treated with medication. I love the discussions that we have had so far regarding the contribution of meditation, yoga, and exercise. So one, women want to be heard. They want to be heard, and they want to not be told you're crazy. They want to be also heard and told, listen, you have had or have risk factors for coronary artery disease or cardiovascular disease, and we're going to treat these. I'm hearing you. Our female patients embrace being heard. So I want to make sure that we are, one, diagnosing it, and two, treating it, and identifying, again, that if we don't treat it, those patients will definitely have a worse outcome from a mortality and morbidity perspective. And we have found that by adding this into our interdisciplinary team, that we have the ability to better address these issues for women. So I think that it is key to realize that there can be a coupling, whether it's the cardiovascular disease that has triggered the anxiety, depression, or panic, or has brought it to the surface, and that those issues can be addressed. And they do not have to be treated with medications. There's so much key. I conduct these twice a month virtual Q&A with Dr. Tracy with my patients in cardiac rehab. And one of my female patients who was told she had anxiety, patient had left anterior descending disease and got a stent. That was triggering her anxiety. Now, because she had this anxiety for so long, it has continued to fester. And she has found, and she showed us this technique, she puts her right hand over her heart. She puts her left hand on her abdomen. She plants her feet on the ground, sitting comfortably in a chair. She closes her eyes and she takes 4 or 5 deep cleansing breaths. After that, she keeps her feet planted on the ground. She keeps her eyes closed, and she continues to take then regular breaths for about 3, 4, or 5 minutes, depending on how much time she has. This technique has been shown to release oxytocin and has been shown to relax patients. She feels a burst of energy. She feels relaxed. She feels less anxious. And so when I say a burst of energy, not frenzy, she feels like now she can conquer things, that she feels less anxious, less panic. That is something that we can do in our car, in our office. We can go into the bathroom and do it. I think this is a great technique to demonstrate to our female patients the strength of mind and being able to know that you can be in control. We also know that with anxiety and depression, there have been studies to show that there can be an increase in platelet aggregation, increase in inflammation, autonomic dysfunction. So there are physiologic components that the anxiety, depression, and panic can affect. And then finally, it can absolutely result in poor health. So patients who have anxiety, depression, panic are going to have those physiologic components. They're going to possibly have higher blood pressure, higher pulse, but they're also going to take poor care of themselves. They're possibly not going to take medications. They may eat poorer. They may not exercise, and their sleep will be affected. So depression or anxiety or panic are key to diagnose and appropriately treat.
Thanks, Dr. Melissa. I think we'll have to go a bit faster from now on. So Nalini, you wanted to ask
Yes,
something.
a quick comment I would ask about, can we have the slide deck on, please? Right. Let me just ask Dr. Annabelle about a quick comment on the link between pregnancy, its complications, and what is the future risk of heart disease?
Yes, this has been a good information that we're spreading around to a lot of doctors, because maternal mortality in the United States has been increasing. So adverse pregnancy outcomes are definitely associated with future heart disease and diabetes. So if a woman has gestational diabetes, they are 3 times more likely than women who did not to develop diabetes later on. So it's a big risk factor. So those include gestational diabetes, gestational hypertension, early birth, premature birth, also small for gestational age infants are risk factors for heart disease for both women and the offspring. Thank you for that question.
Thank you so much, Dr. Annabelle.
Can we have the next slide, please?
Thank you, Dr. Usha, Dr. Annabelle, and Dr. Melissa about really wonderful topic and sharing your experience. My question is to Dr. Melissa. If you could enlighten us about what is heart failure, women should really worry about it. Thank you.
Thank you. I did allude to this earlier, but women can have both systolic heart failure, which is a weakening of their muscle, or they can have diastolic heart failure, which is a stiffening of their muscle. With systolic heart failure, that can occur during or after pregnancy and absolutely needs to be appropriately treated. We are definitely seeing an increase in HFpEF, diastolic heart failure, also heart failure with preserved EF, the acronym is HFpEF, and that is occurring in our female patients, our older patients, and in more of our minority patients. And with the heart failure preserved, the Emperor Preserve trial that was published last year, we finally had the SGLT2 inhibitors, which have been shown to help patients both with systolic heart failure as well as diastolic heart failure. And this is the first treatment that has spanned both systolic and diastolic heart failure, and is the first intervention for diastolic heart failure, HFpEF, ever to show an improvement in cardiac mortality, morbidity, and decreasing hospitalizations. So we now have a treatment specifically that can affect diastolic heart failure. And it's now to the point where we think we should get rid of this systolic and diastolic heart failure and look at heart failure as one paradigm and that there's shades of gray. So women can have both systolic heart failure, weakening of the heart muscle, and they can have diastolic heart failure, which is stiffening of the heart muscle. And this can occur, as I stated, during pregnancy, so in our women in their 20s, 30s, or 40s. And we can then have the development of diastolic heart failure, which can start to occur at any age, but typically is starting to affect women more in late middle age and older. So women absolutely need to be worried about this.
So I think that I'll move to Dr. Usha, ma'am. Dr. Vijayalakshmi is not here, but she wanted to know, how does menopause change a woman's risk for heart health and heart disease?
So I spoke about that briefly, and Annabelle had in the beginning said that we always thought that women had a 10-year advantage over men. And kind of that's because, with menopause and this 10-year advantage, typically we used to get heart problems in the 60s. The moment you have diabetes, this 10-year advantage is wiped out. So as soon as a woman develops diabetes, her risk for heart disease goes up exponentially, and this 10-year advantage is gone, and that's one thing. Now, just if you take menopause, not only I mentioned earlier, the weight is going up, the fat distribution is changing, there's more abdominal fat, therefore more of the insulin resistance, but interestingly, not so interestingly, the good cholesterol goes down, which is typically high in women, within 6 months of the menopause, and the bad cholesterol goes up. So the bad one goes up, good one goes down, weight goes up, distribution changes. So and plus, Dr. Tracy talked about the role of anxiety and stress. So there's also all that going on in a menopausal woman. So all of these things are, adding to increase her risk for heart disease, and these are typically some of the changes. There are many other hormonal changes that are going on.
Yeah, so moving on to the next question, can we have the next slide? Yes. So Dr. Melissa, this is a very common question. There are lots of myths and misconceptions related to statins. So are statins good for women? If you have to give them a message, what would be?
Yes, I can. That's the shortest answer you're going to ever get from me. Okay. So yes.
I totally agree. Let's move on.
Yes. So I think the importance is that we have to treat our female patients as aggressively as we treat our male patients. So absolutely, yes. And I think the only thing that I will add is that one thing that we have found is that high HDLs, really high HDLs, we are looking at particle size for HDL, because we have also found that all particles are not created equal. So if your patient has a very high HDL, but has coronary artery disease, you may want to look at that particle size and see if the predominance of their HDL is large particles, which are the superheroes of the HDL, or are they the small HDL particle size, which can be atherosclerotic. So statins, yes. If you see your patient has a very high HDL, make sure that you're looking at particle size if that is available for you.
Excellent. Yes, ma'am.
I just wanted to add that since we're talking about diabetes and heart disease, the current recommendation is all patients, men and women, after the age of 40, because diabetes is a heart disease equivalent. Having diabetes is like having heart disease. So the recommendation is to add a statin after age 40, even if the cholesterol is normal, because statin provides so many other benefits. I'm just saying that this is the guideline. So because some women have questions about, I have to take it for so long, will it do something to my memory, will it do this and that? So as Melissa very emphatically has said, yes, statins are good for women.
So the house is yes, yes, and yes. Yeah.
Yes.
Can we move to the next question, please? So, Dr. Nalini, you want to ask this question?
Yeah, for Shruti, I just want to ask Dr. Annabelle this question. Is there a link between cancer and heart disease?
So I'm going to try to answer this quickly. So a lot of risk factors for heart disease are also risk factors for cancers. So to stay heart healthy, you're also doing your risk of cancer a favor by staying heart healthy. Unfortunately, the treatment for certain cancers can cause heart disease. So we have to watch those patients who are getting cancer treatments. Thank you.
Thank you so much. Next slide, please.
Yeah. Good evening, everybody. My question is to Dr. Usha Sriram, ma'am. Ma'am, we all as physicians are aware that diabetes and cancer are two very important diseases which are having a great impact on health on people worldwide. Ma'am, is there clearly association and biological link between diabetes and cancer? We'd like you to throw some light on this, ma'am. Thank you.
Thank you, Amala. And Dr. Amala Florida works with me as well, and she actually takes care of our cancer patients. So thank you, Amala, for doing that. And definitely there's a link. As Annabelle mentioned, there's a lot of common soil, whether it's obesity, unhealthy food, physical inactivity, smoking, inflammation, all this common soil is there. And also maybe some, DNA that is, the kind of DNA changes or repair and other things that goes on, again, affected by high blood sugars and poor control. So there's a huge link. Women have much more than men, as I mentioned earlier, 27% more than women without diabetes. Very high on the list: breast cancer, colorectal cancer, oral cancer, liver cancer, pancreas cancer, and lung cancer. The strange thing is, in men, prostate cancer is less in people with diabetes. So why that happens? Lots of theories. One possibility is that men with diabetes may have hypogonadism. So therefore, their testosterone may be lower, and maybe the reason for less prostate cancer is one of that, maybe other reasons. But more cancers in women. So breast, uterus, oral cancers, colorectal, liver, pancreas, all of them. So why this is so important is treatment of the diabetes itself could affect the cancer. Some of the medications we use, if the woman is in poor control, things like that. And conversely, treatment of the cancer affects diabetes really badly, and Amala can attest to that because they use steroids that makes the sugars go up. Radiation and other things make the sugars go up. And appetite and what they can eat. Many times it's liquid food, and that affects diabetes control. And then also this link between longevity due to the cancer and us able to tell the patient to eat healthier and take medications, how to balance the two. So there's a huge, connection between diabetes and cancer. And one of the things that Diwas is right now doing is first doing a large survey across the nation about what is the awareness among physicians, diabetologists, endocrinologists about this link, and among oncologists about the link, and how can endocrinologists, diabetologists, and physicians take care of their patients with diabetes by screening and prevention. We can help our oncologists with this whole screening and prevention because, again, this is a low-hanging fruit. 80 million people with diabetes, we can do our part for cancer prevention. Thank you.
Thank you for your valuable insight, ma'am.
Hi, so it's my privilege to ask the question, Go Red for Women. So what is the Go Red movement and how can we learn more? This is interesting.
Yes, and she's the expert.
So in the 1970s, there were more men dying of heart disease than women. And so the men took care of themselves and the women took care of the men. Unfortunately, the women continued to have the risk. And when the statins came out, the men were treated with statins and the women were treated with hormone replacement therapy because we knew that hormone replacement therapy could increase HDL and decrease the LDL cholesterol. So there were some observational studies that showed that women who were taking hormone replacement therapy had less heart disease. And so the women started to have a lot more heart disease, so that by the 1990s, there were 70,000 more women dying of heart disease than men in the United States. And so the American Heart Association and the NIH decided to raise awareness about heart disease in women. And we use the red dress as the symbol for this. And it's an awareness campaign. We do a lot of research and awareness programs, community activities. There's a big Go Red for Women database that the American Heart Association is compiling and asking them to stay heart healthy. And hopefully all these efforts will decrease heart disease in women and in men. Thank you.
Thank you so much.
And Annabelle has her beautiful red dress pin on her lapel of her jacket. It's beautiful.
Thank you. You too can buy this.
So my question is to Dr. Usha, ma'am. Could you tell us a little bit about pre-diabetes, and is it possible to reverse pre-diabetes?
So thank you, Arundhati, for this question, because I think this is the most important question, in my opinion, as far as diabetes is concerned, because if we can, address pre-diabetes and not allow people to go from pre-diabetes to diabetes and actually go back to normal, which is possible, reversal is possible at this stage. So what is pre-diabetes? So the blood sugar levels, normal fasting sugar should be less than 100 milligrams. And after drinking 75 grams of glucose, and 2 hours later, it should be less than 140. And if we have checked an hemoglobin A1C, which is an average glucose for 3 months, it should be less than 5.7. This is all normal. What is diabetes is if the fasting sugar is 126 or more, if after drinking glucose 2 hours later, the sugar is 200 or more, or if the hemoglobin A1C is 6.5 or more. Any number that falls between these two, fasting between 100 and 125, post-glucose 140 to 199, and A1C 5.7 to 6.4, that's all pre-diabetes. And why it's important to call it as pre-diabetes is we have a tendency to call it as mild diabetes or borderline or a touch of it or something like that. So it's, it doesn't get the importance that it really deserves, because pre-diabetes goes on to become diabetes quickly, and pre-diabetes carries with it a lot of the risk factor, a lot of the complications that diabetes does. And for women, there's something, and this is why I put it in this whole cardiovascular segment, is because they stay in this pre-diabetes for a couple of years more than men. And therefore, in this time, all their cardiovascular risk factors accumulate, and then they end up, therefore, with more heart disease. So this may be the time when we should actually get hold of them and work really hard on making sure that it doesn't go to diabetes, and screen them for all their cardiovascular risk factors and treat them. Annabelle, you want to jump in on this?
No, I think you answered it really well. Thank you.
Okay.
Thank you.
I think we are coming to the last question. Next one. Is there a last question?
Ma'am, it has really been a very, very enthusiastic interaction today, and we've had a wonderful, wonderful enlightenment that we all need to work towards a similar goal. And my last question to all our faculties here is, what should women be aware of in this post-COVID period?
I can start. We've been doing some database registry analysis here at Rush. And so we do a lot of research to be very aware of what's going on with COVID and women. As you know, women are caretakers of many people. And so healthcare workers are predominantly women. So we are taking care of a lot of patients with COVID here at Rush and all over the United States. And because there are more women taking in the healthcare field, there are more women who are at risk for COVID. So we have to be very careful. We have to emphasize how important it is to be vaccinated, because that really can decrease the risk of mortality and severe infections. We need to keep, emphasizing the benefits of vaccinations if we're going to get over this pandemic. But we're worried about the long haul syndrome that we are seeing in our patients. So even if you are not dying from COVID, you can get neurological, cardiac, all kinds of problems after you get COVID. So the most important thing to do is not to get COVID, if at all possible. I'll let others answer.
I just like to chime in about our mental health. It is so important. This pandemic has really affected all of our mental health. We're not meant to be isolating ourselves and not associating ourselves with our family and our friends. So I urge our patients, both female and male, to stay active, get out, continue your appropriate social distancing, wear your mask, absolutely get vaccinated, but get out and stay active, walking, and take good care of yourselves, because this pandemic and coming out of it has absolutely affected all of our mental health.
What I want to add, Dhruvi, is diabetes has been a major risk factor, comorbidity, and what we found, and Dr. Amala and Vijay and I, we have submitted to the IDF Congress in December. One of the papers was, we found that women who were admitted with COVID and diabetes were in poorer control when we looked at their admission A1C. So that told us that women have not been caring for themselves or their diabetes probably during this, these 2 years of lockdown. So now, as soon as things get better, I think everyone with diabetes should go and get themselves checked out and start the full program immediately. And same goes for, I think everyone should go and make sure that they are healthy and nothing has happened to their health in this couple of years. So this is a good opportunity as soon as all the lockdowns are lifted and everything is back to normal, to pay attention to one's health. That's what I would say.
Thank you very much. Thank you very much, ma'am.
I think we've come to the end of the program, and I have to tell you, this has been so incredibly amazing. We've learned so much from both Annabelle and Melissa during this hour and a half or a little more that we have interacted. And then I want to thank every one of the moderators, particularly Tina from Nepal and Aisha from Pakistan. I saw Faria there for briefly from Bangladesh. So these are colleagues who have been so supportive through all these years, and all my colleagues from India who have posed such amazing questions. Annabelle and Melissa, your last words.
Yes, thank you so much for doing this. And the more we do this, the more people are educated. So thank you for doing this. And I learned so much from all of you.
Thank you, Annabelle.
Happy Valentine's Day.
Yes.
Happy Valentine's.
Day, everyone.
Goodbye.
Thank you so much. Thank you.
Thank you. Thank you very much.
Happy
Good night.
Valentine's. Bye-bye. Good
Happy
night.
Valentine's Day.
Bye-bye.
Bye-bye, everybody.
Everyone. Good night.
Bye.
Thank you, ma'am. Thank you.
Just going to take a picture of everyone. You still want to do that?
Yeah, just a moment. I will,
the video on, so Nalini can take a picture. Please.
Thank you.
Thank you. Thank you so much.
Thank you so much. Bye. Good night.